So we'd like to introduce Matt Weiss. Matt participated in one of the previous sessions, and Matt's a pediatric intensivist working in Quebec City. His interest is in deceased donation, and he's going to speak to us with his colleague about clinical practice guidelines and lessons learned from pediatric DCD.
Okay, and then Bram Rochwerg is graduated from the University of Ottawa Medical School, his internship residency at McMaster, where he completed formal research training in Masters of Health Research Methodology program at McMaster. His main focus includes resuscitation medicine, use of fluids and sepsis, and is currently leading a pilot RCT on this topic. He's gained knowledge and expertise in systematic reviews, meta-analysis, network meta-analysis, and randomized controlled trials, and guideline methodology. Thanks.
All right, thanks for those introductions, and thanks for the invitation to speak today. And I know some of the adult clinicians might be nervous about having a pediatrician speak, but I can promise it's only 50% about developmental milestones. You'll see the affiliation slide, no financial disclosures for me or Bram, although we both have professional and intellectual interest in organ donation, which might lead to some bias, but no financial conflicts. This slide I came across recently. It's a quote that I think is important for people considering guideline development. Roughly translated, it says that a physician is not treating humanity in general, but the individual patient in front of them. Came from a 19th century French physician. And I think that's important to keep in mind that as we were developing these guidelines, we wanted to have guidelines that were broad-based enough to apply to a variety of situations, but still left leeway for judgment for a clinician to address their individual patient needs. This was a team sport, a lot of effort from a lot of people all across the country. I thank them all. I can't mention them all, I don't have time, but in the top right you see our professional society partners that we were able to work with, and very pleased to say we also had input from patient partners, which we'd like to expand in future guidelines. The question often comes up, what was the impetus for these pediatric DCD guidelines? And I can say personally, it came from a case. I had a potential donor in my unit. We didn't have the logistic support or the infrastructure to be able to offer that, even though the patient was motivated. Called around, sent some emails, including to Sam Shimmy, who offered me this opportunity to work on these guidelines, not just for Quebec, but nationally. And part of the reason CBS saw this as an important opportunity was because the Canadian environment pre these guideline development, you know, the 2006 DCD guidelines that governed Canadian DCD and still do today are silent on pediatric issues. They don't specifically say they don't apply to kids, but they don't say they do either. And as Graham will talk about, they were done in the pre-grade era and what that means. And on the ground, it meant that only sick kids in CHEO had active programs. There was no national guidance or transparent analysis of pediatric-specific issues. And just like any clinicians, we'd like to have information and guidelines that are specific to our patient population. So in practice, if you looked around the world, so in the UK, there had been between 2007 and 2014, 170% increase in total DCD, pediatric specific. So from 2014 to 2015, there had been 48 deceased donation cases, of which a third were DCD. And that's in the backdrop of about 40% of their adult donation was DCD. In the US, PDCD has also been increasing and more than doubled from 2007 to 2013. In contrast, in Canada, in 2014, it represented about 8% of deceased donation, according to preliminary data from CBS. And obviously, those numbers fluctuate a lot year to year because we have so few cases. So as a transplanted American, the question was, what's going on? Is there something different about Canadians? So in the context, there is a vocal minority against DCD. I know a lot of people in this room have read a lot of these articles, and they question things about DCD in general, but PDCD specifically. So some have questioned whether cardiac PDCD violates the dead donor rule. Other physicians have wondered about DCD and the whether ante-mortem consent is valid, whether DCD in general is kind of a circumvention of the dead donor rule. There were Canadian PICU physicians who published kind of widely controversial questions around all aspects of pediatric DCD, actually calling for a moratorium. And while those positions made a lot of noise and got published a lot, I do want to emphasize that they were really the minority view as opposed to the majority view. And all professional societies who have looked at DCD in general and pediatric DCD specifically have emphasized that it can be practiced in an ethical manner. We have several of the co-authors of this paper, came out in 2013. It's one of many. You can see several professional societies, mostly American, but some international, signing off on the ethics of DCD. And the American Academy of Pediatrics has also commented on specifically on the ethics of DCD in 2010 and 2013, affirming that it can be practiced ethically. And that's informed by the scientific research in the field. So Laura Hornby and others published in 2010 a retrospective review of autoresuscitation, obviously one of the big things that people talk about in opposition to DCD, finding no cases after failed CPR and none in pediatrics. The ongoing DEPICT and DEPART study that Sunny is leading has found that the longest delay to return of circulation has been 89 seconds, well under the recommended wait time of 5 minutes in North American centers. And as PDCD has been accepted more internationally, there hasn't been major ethical or medical concerns with its practice. But still, we were wondering how we were going to develop rigorous clinical practice guidelines, or CPGs. And I wasn't there in Vancouver or in Whistler in 2005 when they had the DCD forum. Now, obviously, that document and that report was very influential, and it had a lot going for it. There was true expert opinion, broad-based participation from across Canada, and they were highly impactful. We wouldn't have DCD in Canada without them. But there were some cons to it. It was done in the pre-GRADE era. GRADE was kind of on the launch pad, but it hadn't really lifted off as a major force in guideline development. There was no formal evidence assessment, and there was no mechanism for updating, which is part of the reason why we still, in 2016, have the same recommendations in Canada. So when we started our process, we wanted to apply a more rigorous process, and we started with a broad scoping review, which has been published. We also convened a forum on the topic to really define the scope, look at what questions we wanted to address. We organized into working groups with diverse expertise, nurses, ethicists, and then we created our professional society partnerships. And I can tell you at the end of 2014, we were feeling good. Things were rolling downhill. We were thinking this was going to be a piece of cake. But then it came time to grade the evidence. Now, grade is a great process, but it's sometimes difficult to apply in all situations. And it was designed to best answer questions through RCTs, although Bram is going to explain exactly why not all the time. Does recommend the use of best available evidence, but the PDCD evidence that we found in our scoping review was uniformly of low or very low quality by grade criteria. The qualitative data did not fit cleanly into grade tables. And many questions were not even answerable with numbers. So, a lot of methodologists in the room, I would challenge them to design an RCT that would answer whether DCD respects the dead donor rule. It's just not that kind of question. So at that point, we weren't feeling good. We were a little lost. We didn't know exactly how we were going to answer these questions. But fortunately, we had someone come to our rescue. He's the next speaker.
It was a pleasure working with Matt and with Sam and with Laura and with the rest of the group, because I'll tell you that this is usually probably more reflective of how panels judge the methodologist. And it's somebody that's there to sort of make sure that people follow best practices, make sure that the linkage to the evidence is discrete and explicit. And I think overall the bigger picture view is that it's probably better to work together in order to overcome misinformation and non-evidence-based recommendations as opposed to not working together. I think the evolution of grade is important in how guidelines ended up where they are. It was US Congress went to the Institute of Medicine in 2008, and there was a lot of heterogeneity in how guidelines were produced at that point. And they wanted to better practice what's important. What do we need to rely on when we sort of look towards trustworthy guidelines? And what resulted from this were 8 standards. And this is published in Clinical Practice Guidelines We Can Trust, which you can find freely available on the web. And the 8 tenets hopefully won't be a surprise to most, and I think that they're things that at least every panel that I work with, it's things that we try to live towards or live by. And I think the number one most important is transparency. Transparency in the process, transparency in the guideline development, transparency in the rationales behind the recommendations themselves. And This part isn't the sexy part of the guidelines. It often ends up in the supplement, that sort of thing. But for us guideline nerds, is that when we're trying to evaluate if a guideline was well done, is that it should be explicit and transparent in terms of how they came to the recommendations. It sort of feeds from transparency as conflict of interest declaration and management. And this pertains to not just financial conflict of interest, but also academic conflict of interest as well. And every society, every guideline group has different ways of managing conflict of interest, but I think it's important that it's at least dealt with transparently and explicitly, and there's some process for whether certain panel members are excluded from certain recommendations or whatever the decision is. This third component has gotten a lot of recognition recently with some of the guidelines and definition documents that have come around, is that it's very important that guideline panels include a vast array of opinions, stakeholders, a variability in terms of gender, race, age, and that folks are well represented on guideline panels. And there's been a big push also recently for patients and families to be involved in guideline panels, which I think is very important. Something that's very difficult to do properly, I'll tell you, but very important nonetheless. Systematic review should be performed to summarize the evidence around each recommendation. And the evidence should be assessed and summarized in a table format, and not only just the evidence provided, but an assessment for certainty in the evidence, and we'll get at a couple of the ways that we do this. There should be careful articulation of the recommendations, very directive statements guiding clinicians in their management. We've all seen recommendations that maybe the recommendation itself is half a page long, and you read the recommendation and you're left wondering, what am I supposed to do with my patient at the end? And I think that there's a lot of a reliance on clear statements. External review, whether that be for peer-reviewed publication, whether that be societal review, or whether that just be content experts in the field. And finally is updating at regular intervals. And I think this is moving towards our ultimate goal, which is living guidelines, or guidelines that get reassessed any time practice-changing evidence gets published. And I think as far as those tenets go, I would argue that GRADE is probably one of the methodologies that best captures those tenets of guideline development, and probably one of the most widely used guideline development methodologies across the world. I show this slide only because I think I'd be doing a disservice to all GRADE methodologists and all of my mentors by not showing it. But it's a quick summary slide in terms of the GRADE process, starting with question prioritization up in the top left corner, systematic review. I do have a mouse cursor. Systematic review of the literature, formulation of evidence profiles based on assessment of certainty of the evidence, which I'll discuss. Here, this is the happy panel in the middle, coming up with recommendations based on the evidence, but also based on other things, like values and preferences, like costs or feasibility or acceptability. Now, this all sounds well and good, but when push comes to shove, I hear from a lot of panels, and this one was an especially significant one, is that, there's no RCTs in pediatric DCD. How do we use GRADE if the evidence is so sparse and so difficult to assess? And I'd come back to that and say is that GRADE mandates that the best evidence is used to guide recommendations. That doesn't necessarily mean that we can only use GRADE if there's randomized controlled trials. The example I'll give is that one of our questions was, should formal prediction tools be used versus no formal prediction tools in terms of predicting the time of death within 30 minutes of withdrawal life support? This is very important in terms of planning for donation after cardiac death. We did a systematic review. We found no RCTs. That's no surprise, but there was 2 observational trials. Now, when we plug this is the best evidence that we can find addressing this question. As you may or may not know, is that randomized control trials in the GRADE infrastructure start as high quality, observational trials start as low quality. But we all know very well done observational trials that might be better than poorly done RCTs. So there's opportunities for both downgrading and upgrading the evidence. Evidence may be downgraded for things like the risk of bias in the individual studies. For things like consistency, did one trial show dramatic benefit and another trial show dramatic harm? How direct was the population studied to the question that we ask? This was very relevant here in the fact that we cared about pediatric DCD, but a lot of our literature was in adult patients. How precise were the results, and was there any evidence of reporting bias? We might rate down for all of these reasons, whereas we might rate up if there's consistent association. things like insulin for diabetic ketoacidosis or antibiotics for shock. We might rate up if there's a consistent and strong association in the literature. And suffice to say is that you can go from looking like sparse data and just observational trials to still building an evidence table like we did for this question, just using the best evidence that we could come up with. And maybe that's not going to be from quantitative analysis and pooled meta-analyses, but it's going to be from more narrative descriptions of the best evidence that we could find. And I think that that's okay. The second question I hear a lot from panels and from people is, well, grade's all well and good, but what about those situations, where we know we're doing the right thing, but there's just no evidence for it? And maybe a good example from pediatric DCD is providing pain management in the time of withdrawal of life support. We feel like that's a good idea, but you're not going to find a study randomizing people to pain management or not to pain management. The other examples I give is, we recommend antibiotics for strep pneumonia. You're not going to find a lot of RCTs delving into this, or intensivists should examine their patients daily, and maybe not all intensivists do, but I think it's probably a good practice. And to deal with these issues related to a lack of direct evidence is that the GRADE working group recently has come up with this idea or this concept of good practice statements. And good practice statements can be made, they're equivalent to almost to strong recommendations, even without good direct evidence. And you might make these in situations where there is net benefit is large and unequivocal, where it's very difficult to summarize the evidence, like in the situation of providing analgesia in the time of withdrawal life support. And still very important to be explicit with your rationale, as we were with the actionable recommendations. The third and final misconception that I think that we dealt with a lot in pediatric DCD was that GRADE only worries about the evidence. And that's simply just not true, is that we all know that there's other things that need to factor into recommendations. The evidence is important. We want to know what the benefit is. We want to know what the harm is. But I think it's also really important to consider other factors: acceptability, the feasibility of implementing a recommendation, the costs associated with this. And GRADE mandates that these things are combined, as well as the evidence and the summary of the evidence. And with this question about, this was another one of our questions, was regional oxygen perfusion techniques for improving organ outcomes in DCD, is that there wasn't a lot of literature looking at this. But when we started thinking about things like feasibility, and when we started thinking about things like cost, is that we ended up with a recommendation against for those reasons. And as I said, that there's this formal process through GRADE that makes us address these different domains, the cost, the feasibility, the acceptability, and the patient's values and preferences, which is often forgotten through this process. This is my summary slide before I turn things back over to Matt. But I'd say overall, I think the mindset is that GRADE is a lot of work. That's probably true, is that using GRADE, it might be more time intensive and resource intensive than the old way of doing guideline development. But I think that the payoff is worth it. Is that ending up with representative panels that are appropriately managed in terms of their conflict, ending up with transparent rationales and judgments so that end users can put themselves in the heads of the committee panel to sort of say, well, I can understand how they came to that recommendation. Explicitly linking the recommendations to the evidence, and not just to the evidence, but how certain are we in the evidence base that's there. And consideration of all relevant factors. And I think that by following these and following GRADE is that, yes, it's more work, but I think in the bottom line is that we end up with more trustworthy and hence more publishable and results and better patient care.
Okay, thanks, Bram. And I'm going to wrap up quickly. I know we've got the plenary starting in just a few minutes. So I'm just going to show a couple of the recommendations. The process did generate 65 good practice statements. Now, obviously, there are probably some great folks in the room a little nervous about that, but that was the type of data that we had to work with and the type of questions we were asking. We did have 7 actionable recommendations, for which we were able to make a recommendation in 3. For the 4 others, there was a balance of benefit and harm, as Bram mentioned. And one of the most important things, we have a list of research priorities that we hope to be able to address over the next few years. So these are a couple examples of our actionable recommendations. We do suggest a 5-minute wait time. We considered a 10-minute wait time, but considering the lack of published evidence around a 10-minute time and the potential harm, we recommend a 5-minute waiting period, long enough to be outside of the possibility of auto-resuscitation. We specifically did not make a recommendation around the universal administration of heparin. Once again, we couldn't find evidence of benefit. We couldn't find evidence of harm. If an ODO and a surgeon request heparin to go forward, we certainly support that decision, but we do not support the universal administration. A couple examples of good practice statements. Just show some from the cardiac section where we analyzed the ethical analysis around cardiac DCD and found that it did not violate the dead donor rule, but certainly also recommend that any program that was looking to establish a cardiac PDCD program would have explicit protocols around it, see how ex vivo may or may not be used, probably with oversight from an REB or Innovative Therapy Board. Our research agenda, and we're going to be calling out to people in this room to help us answer some of these questions. We need better understandings of inclusion and exclusion criteria, both for donors and recipients. It would be a shame to do all this work to develop a donor base only to have nowhere for the organs to go. We need better research into the risks and benefits of anti-mortem therapies. We need to better understand the Canadian donor potential. How many potential donors are there out there? And we really need a better understanding of family experience in DCD in general, PDCD specifically. Those are just some of the research questions around there. We do have some limitations, relatively novel application of some of these grade concepts with multiple good practice statements. The evidence base was of poor quality. That's a limit that we couldn't get around. We weren't able to get our patient partners involved early. They were involved late in the process. And there were potential biases from the sponsor and ourselves with our inherent biases. So immediate impact, there have been 4 cases since the start of this process in all of those cases, they were members of our working groups. So we're happy to see that implementation happening. Multiple programs are under development, and we had our first case of multi-organ DCD in my hospital in May. Future impact. So CBS is looking to take these concepts of clinical practice guideline development and apply them to future guideline development. And we're looking for better pediatric data monitoring, and we're looking to develop knowledge translation processes and tools. Here's a website that CBS is developing. We encourage all of you to go to it when you have questions around organ donation. We're going to put our leading practices and guidelines there.